Hi, my name is Ethan Korngold, and this is a 2020 Vascular Access Update. Here are my disclosures. So we'll start with radial first. 2020 is a good year because radial artery access is nearing 50% of all PCI volume in the United States. And in January was published the SCAI Consensus Statement on Transradial Angiography and Intervention. This is a really excellent resource. I highly recommend it. It comes with a bunch of useful recommendations. The first of which that stood out to me was that the Allen's test is finally done with. Recommendation is that transradial angiography can be performed regardless of the results of non-invasive collateral testing, and that routine collateral testing should not be used. 2020 also saw a publication of the Safari STEMI trial. This is a trial of 2292 patients with STEMI that were randomized 1-to-1 radial to femoral for primary PCI and was stopped due to futility. This was a surprising result because there is really no expected advantage seen over femoral access in STEMI. And one of the issues pointed out was that this is modern femoral arterial access. Vascular closure devices were used in 68% of the femoral group. There was low 2B3A use, high bivalve use. Ultrasound use is unclear, but it's these factors likely contributed to the lack of a difference being seen. That being said, 2020 also saw the publication of a meta-analysis that specifically looked at the question of radial artery intervention compared to femoral artery intervention with the use of a closure device. And what it showed is that even with the use of a femoral closure device, there was less major bleeding and less vascular complication in the radial group. The SURF trial was a 2x2 trial in PCI looking at radial versus femoral and use of ultrasound versus no ultrasound guidance. And what that showed was that radial intervention had less MACE, bleeding, and vascular complications than femoral. In the ultrasound group, there was no difference in the primary endpoint, but ultrasound was better with access time, number of attempts, difficult access, and first pass success. This comes at no surprise. This was shown in the FAUST trial in 2010, showing superiority of ultrasound in femoral access, and in the ROUST trial, showing that ultrasound was superior in radial artery access. So based on this, the SCAI recommendation is that operators should develop proficiency with ultrasound guidance to facilitate forearm vascular access, and that real-time ultrasound guidance should be available and used when difficulty with radial access is encountered or expected. My feeling about ultrasound in radial or femoral access is it's like masks. It's time to stop debating it. It's time to just use them for every case. What about distal radial, the darling of cardio Twitter? So first of all, why do people go distal radial? Well, it's much easier when the left radial is used. It has advantages in patient comfort, faster hemostasis, less danger of occlusion, and this was a good year for data coming out for distal radial access. So first of all, study looking at distal radial artery size. The distal radial artery is certainly big enough. It's slightly smaller than forearm radial artery, but certainly big enough for 5, 6, 7, even 8 French sheaths for intervention. Distal radial artery leads to faster hemostasis. Look, it even made the cover of CCI in November of 2019. This study looking at distal radial versus radial showed 99.5% success rate for distal transradial with low complication rate, and showed improved time to hemostasis for distal radial compared to traditional radial. This Japanese multi-center trial looking at 228 patients showed low complication rates with distal radial. And this randomized trial that was presented at EuroPCR just recently compared distal radial to radial, showing significantly lower occlusion with duplex ultrasound at 24 hours with distal radial compared to traditional radial. This meta-analysis, which is electronically available in CRM, shows shows also significantly less rate of occlusion with distal radial compared to traditional radial. So distal radial is definitely gaining in acceptance. I have a separate talk on CVI on demand if you're interested in more technical aspects of the procedure. Shockwave intravascular lithoplasty has gained a lot of interest as a way of facilitating large bore vascular access for Impella, TAVR, and EVAR-TEVAR. So this series was published in 2020 of using intravascular lithotripsy for Impella. This is a series of 12 patients showing successful Impella insertion in 100% of cases and 0 complications in this series. Just to briefly show how this works, here's a 91-year-old woman or a 91-year-old man with severe aortic stenosis who needed Impella-supported multivessel PCI with a minimum femoral diameter of 2.4 millimeters. This was treated with IVL with a 7 millimeter balloon, which then facilitated challenging but achievable Impella sheath placement. This technique is very conducive to the single access Impella sheath technique, where up to 7 French access can be obtained alongside the Impella catheter using the same Impella sheath. And then this shows the post-PCI angiograms. You can see the femoral and iliac arteries are intact. Now there's a real advantage to staying transfemoral over alternative access when it comes to TAVR. And in 2020, this series of 42 patients looked at valve delivery, which was 100%, and very low rate of complications using IVL to facilitate TAVR access. Here's a case of a 77-year-old woman who needed a 29 millimeter Evolut Pro despite this concentric iliac stenosis. And after shockwave with a 7 millimeter balloon, there was challenging but still achievable deployment of a core valve. And here's final angiogram showing that the iliacs are intact. So in summary, access for 2020, radial first continues to grow. Ultrasound, use it for radial, use it for femoral. Distal radial access is worth a try. And intravascular lithotripsy is a very useful tool in the toolbox for borderline large bore femoral access. Thanks very much. If you have any questions, please feel free to reach out to me at ethankorngold@providence.org or Twitter @EKGPDX. Thank you.